Thank you. Welcome to this meeting of the Health and Wellbeing Board, held on Monday, the 4th of December 2023. For those present in the meeting room, if the fire alarm sounds, please leave the building by the nearest exit and proceed to the assembly area in the car park. The agenda papers and other relevant information for this meeting are available for public viewing on the Herefordshire Council website. The Council is streaming this meeting live on the Herefordshire Council YouTube channel and is making a recording. To ensure that recording quality is maintained, please speak as clearly as possible and keep background noise to a minimum. Please ensure that mobile phones and other devices are turned to silent. Others are permitted to film, photograph and record our public meetings, providing that it does not disrupt the business of the meeting. If there are any members of the public, which there aren't, then we would wish, if they did not wish to be filmed, we would ask them to raise their hand so that such persons filming or making photographs may be made aware. The procedure and etiquette for the meeting, voting will be undertaken by a show of hands in the room and only committee members may vote. For participants in the room, please use the microphones to speak. And there's, as you will see, these are relatively new microphones, and therefore in order to speak, please press the button on the right of the unit. Okay? And speak directly into the microphone. We have a number of people, I believe, in the attendance as virtual participants, and can I request that they use the raise hand function within the system if they wish to contribute. Now, my understanding, and if they are virtually here, perhaps they could tell me so, John Butlin.
Yes, I'm here, Chair.
Thank you. Kevin Crompton. No. Susan Harris.
Yes, I'm here, Chair.
Thank you. Dr. Mike Hearn. And Superintendent Helen Wayne.
Yes, good afternoon, I'm here.
Have I missed anybody out? Who's that?
Alan Dawson from Wye Valley NHS Trust. I'm here on behalf of Jane Ives, who's on leave.
Ah, and you're virtual. Okay, thank you very much. So, we have apologies for absence. What apologies have been notified to the clerk?
We have received apologies from Jane Ives and Simon Trickett.
Do we have any named substitutes?
Alan Dawson.
Alan Dawson. Okay. Item 3, declarations of interest. Do any members wish to declare any table A and or B table of other interests in this agenda item, in any of the agenda items? Nope. Minutes. The minutes of the meeting held on the 25th of September 2023 are included in the agenda pack at pages 7 to 12 for approval. Does anybody have any queries with regards to those minutes? No? I therefore move that the minutes, subject to no amendments, be signed as a correct record. Do I have a second of that? Matt. Okay. Any against? Any abstentions? Item 5, questions from members of the public. No questions have been received for this meeting.
Yeah, no questions have been received.
Questions from councillors?
no questions either.
Item 7 is the JSNA review, and I'd like to ask Rob Davis, Consultant in Public Health, Community Wellbeing, to present the report. Thank you.
Thank you very much, Chair, and to those in the room and online. Hopefully this is coming through clearly. So this item is on the Joint Strategic Needs Assessment and a review we've been undertaking over the last 3 months. So as a reminder for all, the Joint Strategic Needs Assessment, JSNA for short, is the process by which local authorities and the NHS jointly assess current and future health need, with the direct aim to inform local decision making and improving the wellbeing of Herefordshire residents. This includes health behaviours like smoking, diet and exercise and statistics on that, as well as the social factors that impact them, such as housing, poverty and employment. The process is made up of 2 main elements: the information element, often known as the evidence base, and the process of making sense of that information to make joint strategic decisions. So we wanted to assess whether our current JSNA process was fit for purpose after a number of years of rolling with different changes at the local authority, NHS and with the COVID pandemic, and to reveal key strengths and weaknesses of our process to make recommendations to improve next year and beyond. To do that, we set about looking at website hits for our Understanding Herefordshire website. We looked at subscriber feedback online, and we also talked to around 60 people individually or via groups who were using the JSNA to make decisions, either service improvement or financial decisions, commissioning decisions of that type. And that was a really rich source of data that led to almost 300 kind of unique lines of information that has been processed as part of this review. We also didn't just look at our own practice, we searched out best practice from national and regional colleagues, and we looked at other JSNAs from other areas in and outside the West Midlands. So what we found in terms of the strengths was that our JSNA is clearly informing some work or in a light touch manner, although it is driving far less. Where it is driving change and decisions, it's in the form of bespoke needs assessments driven by multi-agency groups, and by that I mean providers, the NHS and local authority working together in a group to say what services are needed for these residents and how can we improve, and what does the evidence tell us we should do. An example of that is the 0 to 19's needs assessment linked to the recommissioning of that service. We identified up to 9 weaknesses as well. I won't go through all the strengths, there are other strengths in the report, and there are other weaknesses in the report. I'll just give you a flavour of those here. Some of the weaknesses relative to best practice were around the joint element of the joint needs assessment. So the lack of balance between the local authority and NHS in terms of how they're directing the work, how they're administrating the work, and who's setting the scope. So that is a finding that we found across the region, across the nation, and with different examples that we looked at, but it's still an ambition that we think is crucial to crack. So it remains in the weakness column. And another one related to that is a governance gap. So because much of the JSNA is partnership work, a lot of the scoping decisions and what's useful to who and what products are useful can't be made individually, and they need a multi-agency partnership group to guide that decision-making and process. And currently we don't have one that's directly responsible for the JSNA. So in terms of opportunities, from best practice and from looking at other examples, there are a lot of opportunities to improve our JSNA, and there's a lot of appetite from the different groups we spoke to improve things, and there's also clear options on how to do that. A fundamental rejuvenation of the JSNA would require, for example, discussing and documenting answers to one of the best practice documents listed in your pack from the Local Government Association. That includes real prickly questions such as, to what extent will the health and wellbeing rationale drive all strategies across the council and NHS? To what extent should that go to economic regeneration and housing, or to what degree should that stay in health and social care? There's also the issue around who will our JSNA primarily speak to? Is it the public? Is it commissioners? Is it elected members? Voluntary and community sector? If it's all of those, are we ready for a debate around how we use data and information collectively, move money around the system as a result of those discussions? So these are big questions, but there are frameworks to work through that as a steering group and as a board and as a group. There are other best practice examples from Public Health England, and we've also reviewed and documented some of the best practice from other areas as well. So there's three kind of main sources of improvement that we can pick from, and they provide a clear path to address those weaknesses and amplify some of our strengths. But that does leave the question of who decides all this. So who decides which bit of the best practice we do? Who decides what bits of other JSNAs we want to take on, or should take on, or can take on in Herefordshire? And that's why we've resisted in the report the temptation to make those recommendations unilaterally from a local authority or a public health or analytical perspective, because we think this perpetuates one of the main weaknesses revealed in the review itself. So instead, the main opportunity is to define a partnership group that can work through those best practice options, make those decisions on behalf of the JSNA users themselves. So these judgments have not been made explicitly for years, so may take time and challenging conversations to work through, fully, document and then implement. But in our favour, these options are already well framed. They're distilled into sort of decision frameworks and questions, and there's a lot of appetite to move in that direction. So that brings us to the recommendations in the report, which are to establish a JSNA steering group to respond specifically to the findings in this review, to maintain that steering group to make ongoing partnership decisions in the future, including on how the JSNA should look, its function, how it's administered, and the governance structure around it. And we recommend that this function should be incorporated within one Herefordshire partnership, with the ability to involve additional partners as needed. Thank you, Chair.
Thank you. Does anybody have any questions they'd like to ask about this report? Ms. Rooster.
I was just trying to, sorry, getting used to the microphone. In terms of its current practical use, I was just trying to think of a scenario in my head in terms of how it is actually used. So when a PCN prioritises frailty or obesity, is that informed by the Joint Strategic Needs Assessment, or is that from other data sets?
To some degree. So the JSNA is a bit of a collector term for what information would they use to make that decision. We've heard from PCN leads that they do go on, for example, Understanding Herefordshire, which is our website with a lot of profiles there, so they understand what they can from that source and they supplement it with their own records from EMIS or whatever. They piece that together and try and make the best informed decision. But there are products, for example, PCN profiles, that are a bit more targeted towards their needs, or do we want to develop the capability that they can ring up a group of analysts to have a more in-depth conversation to inform the specific issues that they're trying to develop? So there's something there, but there could potentially be more. Does that answer your question?
Yeah, to just say thanks, Rob, for a great piece of work. And like you, Steve, I think I was always quite quick to look at what's the end product that we need. And I think what Rob and colleagues have put together is a bit of it's a proposal of actually we bring everyone together to really understand how we kind of share and use data and intelligence collectively. And I think that's really important. What are our priorities? I think the primary care networks, that's come through quite strongly in terms of how they use data and intelligence. I think we have to remember this came back from 2012 Health and Social Care Act. So, you know, this has to be the driving force of the Health and Wellbeing Board in terms of how we set our priorities through the Health and Wellbeing strategy, but also voluntary community sector. And I think one thing that came through really strong was the community voice in this as well, which I think a lot of joint strategic needs assessments always fall quite low on, I think, is how we can kind of complement that epidemiology and data to actually what our communities need, is how we kind of bring that together going forward. But I think it's a good piece of work. I think what we probably require is system partners to all come together, how can we really bring all our data sets together and truly understand how we can get the JSNA to a place that we all want it to be and can inform all our work together. It should be that really single version of the truth, I think.
Got conscious there are people up on the screen as well, but specifically responding to Matt's point, we're doing some work across the system on something called population health management to look at how we join up all of the data sets. So we've got a lot of primary care data, got the hospital data set, we've got stuff from the community services, mental health services, etc. And a lot of other sources of information from housing providers, social care providers, etc. What we need to do through that piece of work is trying to create a platform where we can join all that information together, get it into the hands of the right people so they can make decisions based upon it. And some of the primary care plans that you referred to have been started with that basis, but predominantly just the primary care data, not the wider data sets that necessarily underpin it and inform it. So there's a lot more work to do on that, but we're very keen to be part of it and support from a system perspective across both counties in any way we can.
I just got a couple of points really. Looking at the local government summary of their toolkit questions, it puts quite a big emphasis upon involving as many voluntary organisations as possible as you can, such as citizens' advice, users, carers, disability groups. And I think that is really important because we know what we know, but we don't know what we don't know. And citizens' advice probably have got a lot of information about deprivation, etc., that we don't necessarily know, and similarly with the voluntary sector and the disability groups. So I would certainly want to be clear that I would think we need to do some work around that. And then when I looked at the best practice and the reviewing the options that other local authorities had done, the one that really stuck out with me, because I'm a simple soul, is I thought that the website for Wigan, I don't know whether you've ever looked at it. Yeah, obviously didn't. But if you look at the website for Wigan on that, if you click onto the best practice and you look at Wigan, it is one of the simplest websites to follow that I have probably ever seen. And I thought, if you are not a person who works in a local authority or a hospital trust, etc., and you are somebody who wants to know information about your area, it needs to be as simple as possible. And Wigan is so simple, and yet it's quite clever. I mean, I don't know whether it actually achieves all that we're looking at, but it's a really, really clever website, and I think it's something that we can learn from its makeup. The other couple of points I just wanted to make was, I think the idea of developing an annual JSNA work plan linked to the strategic planning and commissioning, I think that's a good idea. I don't know whether you do, but I thought it was a good idea. And I also thought that the steering group making JSNA decisions with knowledge of the capacity and capabilities of intelligence unit and NHS and analytical resources was also a good idea. So they're the points that I wanted to make, really. Rob? Oh, sorry. Kevin?
Thanks, Chair. Can you hear me okay? Hello, can you hear me?
Yes.
Yes, sorry, beg your pardon. Sorry, just an observation. Matt's already made the point, but chairing both your safeguarding boards, I'm constantly coming across this need to get multi-agency data together, which is used as evidence to try to inform policy, is used to assess progress, to assess service delivery. And I think, Matt, in another forum, we had the same discussion about the need to get a multi-agency group together to look at what data we've got and to sift it to get the stuff that does the best job for us. So I just wanted to add my voice to those in the room who said similar.
Alan?
Thank you. It was just a comment first, and then a plea. In terms of the document, I absolutely support it, and it's a good piece of work. In my role, use the JSNA quite a lot for sort of planning services, and use it consistently over time. Tend to go back to it. And it's really for a plea for consistency of information in the JSNA, because often it's something that we go back to when we're planning services, and occasionally you can go back to JSNAs and the information that was there last year isn't there this year. So it was just making sure that we've got some consistency over time. There's sort of core set of information in there that is consistently monitored and presented.
Are you looking for a representative from the voluntary community sector to be part of this group moving forward?
Forgive me, it depends on what the current membership. Our recommendation is that it falls within 1HP, and we're under the impression that they have a plus element, but I'm not sure what the core and membership of that directly is, but that would be for the group to incorporate who they see fit, I think.
Christine, did you want to?
Yeah, so I do go to 1HP, but I think in the past with the JSNA we've gone out with the intention to seek wider views from the voluntary sector at the community partnership. I think the difficulty with that is that you can inform broad discussions, but where we'd want to see things go is organisations giving data to the JSNA process on a more substantial basis, which I think we might need to think through how that works. We couldn't have all organisations on a subgroup potentially. So I think we'd need to think about the conduit for regular involvement and feeding in data from the voluntary sector.
Well, it would, if we're going to start using that local intelligence, there need to be a consistent way of reporting. Otherwise, we'll have ad hoc data sets flying around all over the place. So if there's an opportunity to influence or consult with the VCS sector, I'm sure they'd appreciate it. Yeah, and having a voice at the table, because I think you alluded to it in your report in terms of the voluntary sector can use it to build applications for funding, but to actually drive the work, I think you hit the nail on the head in your report. They will go to it to get some useful statistics, but yeah, so I think there's an opportunity here, that's all, to involve the VCS.
Yeah, I think, Steve, so when Herefordshire Partnership's not going to be able to do all the work, I think there's going to be lots of work that sits below that, the kind of operational stuff, the stakeholder engagement linked with the voluntary and community sector to make sure that what proposals go forward to 1HP kind of represent the broad range of different stakeholders and partners. So I think that's probably how I foreseen it happening. So we can certainly link the voluntary and community sector in. Obviously, we'd engage groups like the community partnership as well, just to make sure it does. Because I think there's so many stakeholders and needs, and people have slightly different needs of the JSNA. It's how we kind of fulfil all that. So I think we're going to have to engage a whole suite of stakeholders in order for us to do that. So happy to have that conversation offline and how we can do that.
So we go then to the vote. All those in favour of the recommendations as printed, please show by hands. Anyone against? Anyone abstaining? That's carried. Thank you. We move on to item 8, which is an update on the progress of the Health and Wellbeing Strategy draft implementation plans for the two key priorities, Best Start in Life and Good Mental Health. And this will be presented by Lindsay McCarty, Public Health Principal. Thank you. Oh, and can I also just introduce Christian Pritchard, who I believe will answer any questions that come along that Lindsay feels are more appropriately aimed at Christian.
Thank you, yes. Matt, I wasn't sure if you wanted to introduce the paper or do you want me just to go into it?
I'm happy for you to do it, if you like.
Okey-doke. Thank you very much. Thank you, Chair. So in terms of the this paper, really, it's to provide an update to the board on where we've got to in developing the implementation plans to support the health and wellbeing strategy that was launched in the summer this year, and obviously you're overseeing that. It's this board strategy, so it's important to make sure that we're bringing regular updates to you and that you're influencing what goes into the implementation plans. So we wanted to specifically bring both plans for the two key priority areas of Best Start in Life and good mental health across the lifetime to identify some specific actions and timescales in order to achieve some of the outcomes that we're looking to. It is an iterative process. The strategy is a 10-year strategy to 2023, 33. But so what we wanted to do, though, was identify some shorter term goals so that we're covering 1 to 2 years in the first instance. And I think we've identified some fairly quick wins for that. But then obviously things change. We've just been talking about the JSNA. The data might change. We might need to shift our focus a little bit. So we're very happy to do that. And these plans are therefore not static. They're dynamic plans, and we want to be fleet of foot about how we go about implementing them. We also need to be very careful about making sure we're aligning with other plans. We've got other strategies that are in place and in development. I'm very mindful, particularly in the arena of children and young people. We've got the early help strategy that's recently been developed. We've got the SEND strategy. So we need to make sure that the implementation plans and actions all dovetail with the delivery plans that go along with those strategies. And the ICS and ICB strategies as well. So there is an NHS transformation plan for children and young people, for example. So we need to make sure that all of the activities align with the activities across particularly Herefordshire, but in also some instances with Worcestershire too. We've developed a way of engaging, planning the actions, identifying the actions, and then thinking about what are the capabilities needed to take those forward, and therefore what kind of measures we're looking for to assess whether or not they're effective. And it's come from something called a public sector scorecard, which is also used across the voluntary and community sectors as well. It's not just for the public sector. And it's really based on an outcomes-focused approach and probably a little bit more comprehensive than a straightforward logic model. But that's the kind of model that it is. So we have engaged with a whole range of groups. We've engaged with partners across the county. We have used the Early Years Partnership, which is a subgroup of the Children and Young People's Partnership, to identify further partners kind of across the system who we want to engage with. We've had a series of think tank events. We've worked with the mental health partner groups that we've got across the county, both children and young people's mental health and wellbeing groups, and also the New Better Mental Health Partnership, which was essentially the adults mental health partnership previously, and 1HP. I'm not saying that we've absolutely engaged with everybody, but we have tried to engage with as many as possible in order to identify our actions. And of course, through the launch, there was huge engagement. I think we had something like 100 participants at that. So we've had a lot of people feeding into both of these plans. I think so far, in terms of feedback to note, really, there's been a lot of positivity, and people are kind of saying very much the same sorts of things, looking for better integration, looking for better data sets and more integrated data sets, looking for different ways of working really in order to achieve our goals. Communications has come up quite a lot, as you might expect, in both of the implementation plans. So I think at 1HP last week, there was a question around whether we actually needed a communications plan to sit alongside each of the plans. And we may well do, or we might want to think a little bit differently and thematically about where the communications need to be. And there was also a question really about 1HP obviously is seen as sort of the delivery group for this board, and the Children and Young People's Partnership group board feeds into both 1HP and this board. So there is a kind of question, I think, around how we should ensure that governance is right and how we get the accountabilities right, and that will be at the direction really of this board. So in terms of recommendations, it's really just to consider and note the progress of where we've got to in a relatively short time, to consider the response, your response rather, to the draft plans as they stand, and be looking for comments, your active involvement, any contributions really, and not necessarily this afternoon. I think we would like you to be able to have a think about it and maybe engage with your own networks and get some feedback to us so that we can update the implementation plans. And then to agree to have twice yearly updates. I'm not going to go into all of the detail of the implementation plans just now. I've got some headlines for you, but actually there is a lot of detail in each of them. So we're wanting to suggest that both of the plans come to this board twice a year. So we alternate, in fact, so that at every Health and Wellbeing Board meeting, one or other implementation plan is brought to you for discussion. Just briefly, in terms of the underlying principles which are in the strategy, and you'll all be very familiar with them, we're wanting to focus on prevention and reducing health inequalities, working with communities, and obviously Christine's going to talk a bit about community paradigm and co-production and how we can develop that more effectively, more efficiently, and with greater granularity, I think, so it's not superficial. We definitely want to look at different ways of integrating work forces and ways of working, recognising that our workforces will have to think about change and doing things differently. So that sometimes brings its own challenges. Definitely want to have everything evidence informed and data informed as well, and being focused on outcomes. So very briefly, in terms of the best start in life, our overarching ambitions are around all children enjoying good health and well-being, but just a reminder that best start in life focuses on the 0 to 5s. So it does actually also include the preconception stage. So we are talking about families as well as children. We want children to be protected from harm at home and in their community. We want children to be able to achieve their early milestones in all settings, and for parents to be well supported at all stages of pregnancy and after the birth of the child or children. So in terms of the implementation plan, as I say, the detail is in the documentation in the appendix. But really the kind of the overarching cross-cutting themes that I think are absolutely crucial for this is about integrating teams right across the service. So we've got the primary care neighbourhood teams approach. We already have, for example, our health visitors and school nurses linked to primary care networks and to various schools or nurseries or whatever, and it's really just to build on that. And there was a comment a month or so ago about is this plan very ambitious? Because some of it doesn't necessarily look very ambitious. I think it's really easy to say words like integration and corporately owned and managed, and even talking about data sets, that's really a bit of a minefield. I think if we can get some of these cross-cutting issues right, that will be absolutely a fantastic achievement. So I'm really excited that in so many services, so many areas across the county, people are really up for doing things differently. We want to have better cross-partner communications. That has come up consistently. Parents don't know where to go for information. Professionals don't know where to go for information. There are websites all over the place. They don't necessarily link up. And that's not through any fault of anybody's. It's just actually we really need to make sure that it's our public that are the ones who are saying we need to know where to go for information and be able to access it very easily. We've talked about data sets. We definitely need a cross-sector dashboard, and we really want to make sure that the voice of the child and the families come through so that they're influencing what we take forward. And in terms of our ambitions, these are some of the kind of the big longer term outcomes, some of these. So we need to look at measures against our specific actions that will be the steps towards some of these larger outcomes. So we know we need to reduce tooth decay. We need to actually reduce the number of children in the county who are starting school now overweight, not just ending primary school very overweight. We have got increasing numbers starting at age 4 and 5 who are very overweight. We want to increase, we've got very good numbers of children achieving their 2.5-year developmental check levels, but actually we need to be focusing on those children that either aren't achieving or aren't actually having the check done. So we really want to kind of drill into some of these so that we make sure that we're achieving good outcomes for all of our children, but also identifying where we need to achieve some specifically good outcomes for children who are maybe lagging behind a bit. So I won't go through any more of that one, but I will just go on to good mental health. And many of the same kind of actions and principles and ways of working apply to this. So throughout our life, we want people to feel satisfied and have a positive sense of personal well-being. We want our families and for individuals to be able to access appropriate mental health information and services, people to feel safe from harm in their community. And I think one of the crucial things is to feel connected to their community. In Herefordshire, I think we do that really well, but we also know that there are pockets where they don't. And we also know in terms of our young people that actually, certainly from the ages of sort of 15 to 25, they feel less connected either to their school or their college or their community. So in terms of the cross-cutting themes for the good mental health, we want to make sure that we've signed up to the National Prevention Concordat for better mental health. A few years ago, some of you may or may not remember, we had a joint exercise with Worcestershire Council members to look at what we needed to do to sign up to the Concordat. So I'm hoping that that would be actually something very positive and something that's relatively straightforward to do. We want to deliver a mental health needs assessment, which is currently underway, again with a specific focus around prevention. We're not talking about a mental health needs assessment that focuses on crisis or treatment or facilities and services. It's much more upstream, hopefully. And again, to look at some kind of communications plan to ensure that every mind matters. Again, in terms of the overarching ambitions, we've identified some higher level outcomes that we're wanting to achieve. Again, most of these will be longer term, but there are some steps that we can take in the meantime to get us to those places. And one of those at the top there, reducing the rates of suicide, that's not a short-term objective at all, but we have just appointed a suicide prevention officer. So we're hoping that in Herefordshire we can now start to drive some of the work that we haven't been able to, as our counterparts have in Worcestershire. So I'm going to stop there. I have got a list of, obviously anybody can contact me, very happy to take any notes or questions or whatever. Julia Stevens is the public health lead for children and young people, Best Start in Life, so 0 to 5s. And Kristen, my colleague here, is the public health lead for mental health and wellbeing across the life course. So again, there are some specific contacts if board members have any specific queries. Thank you.
Before I ask a committee if they've got any questions, there's just two that I would like to comment on. One is this the Healthy Tots programme and the toolkits that are provided. And we obviously are working with community pubs, children's centres, etc., etc. What about the TOTS groups that are set up within villages, communities, etc.? I mean, I've got one in my own village. I doubt whether you even know about it. There's 20, 30 TOTS go to that. They don't all come from within the village. They come from the surrounding villages as well. And I just wonder how many of those there are and whether we've actually got more TOTS that we don't know about in groups outside of our settings who aren't able, or at the present moment, we are not sort of communicating with because we don't know they exist.
It's a really good question, and we also know that lots of them aren't on, say, for example, the Talk Community Directory because they don't know how long they're going to last, they don't know how many people they're going to be able to continue and so on. So it's a good question, and one of the things that we've identified in the action plan is around working with the parish councils, working with the local communities in a different way so that we can identify some of those groups. And the Healthy Tots framework really is going to be about any group or nursery setting or childminder for that matter, because we want to roll it out as widely as possible, and primary schools to be able to say, where do you think you are, where do you think you might need some support, what are the things that you've noticed about the children in your care, so that we can work with those issues that they're particularly keen on. And we know that approach works because with the supervised toothbrushing programme, we had thought that we'd be lucky to get, say, 10 nurseries involved in that, in terms of the kind of feedback we'd had beforehand, which was, no, we won't be doing that, we haven't got time to be doing toothbrushing. We've now just enrolled our 40th setting in the supervised toothbrushing scheme. So I do think that there's a real element of word of mouth as well. So if in one local area we can get things up and running, it will encourage others to stick their hands up and say, actually, could you come and work with us as well, please?
So how are we going to communicate to parish councils that we would want them to either let us know or speak to their TOTS group, to speak to Herefordshire Council to let us know that they exist?
I'm hoping that we can get communications out to them, but we'll also do some launch events. So we're wanting we're going to do a small pilot project with the Healthy Tots, Healthy Schools framework with a number of settings that we've identified. And then we want to do a series of launches to encourage others to come forward. And as I say, to have as wide a variety of settings and interest groups as possible.
The other point, which for me is a bit of a sore really, for about the last 6 years now, we've been talking about improving the health of children's teeth in Herefordshire. I think about 6 years ago we had, as a scrutiny committee, a whole day discussing this issue, and we don't seem to be getting very much further forward on this. And I know we had I think a dentist that came forward from the south of the county that was prepared to take on NHS patients but couldn't find a premises to actually operate out of. And I just wonder, are we making progress here? I recognise that we're not alone, but are we making progress, or are we still where we were 6 years ago when we first raised this?
I'm hoping we're not quite in the same place that we were. Obviously, even things like the supervised toothbrushing scheme takes time to come through. So we're now 2 years into that. So we should be starting to see some of the impact of that. We've been looking into whether or not fluoride varnishing is a possibility for us, because children can't access the dentist. So we know that they're probably not accessing fluoride varnishing. I think we do have some good news. I think it's gone a bit up and down with that new dental practice. So I think the news is a bit more positive again this week. But yes, the premises fell through. And my understanding is that there are actually 2 practices that will be starting in the new year, which would cover something like 30,000 people. And we have requested that they identify, you know, a number of places for example, under ones, or at least set aside some so that you don't get completely swamped. And then we're back to the drawing board in terms of waiting lists for people and know where to go. So yes, we do have our oral health improvement plan. And I think as part of some of this coordinated activity and things like the Healthy Tots framework, actually those are fairly simple things to start getting in place. Can identify dental health is a crucial issue. So what are we going to do about it? I'm working again with Children's Centre Services to see if they can share some of these targets and what actions they can take. But I agree, it's very slow, and it feels really difficult because it's such an important preventative thing to do. But yeah, time to shine and healthy smiles is what we're after for all of our population, but we need to start them very young.
Sue?
Thanks, Lindsay. Really helpful presentation. I just wanted to make a few points of clarity for the committee to let you all be aware that we've obviously got a mental health collaborative that sits across both counties, and Lindsay referenced in her presentation about the Better Mental Health Partnership, which is the place-based conversation. So it sits under the One Herefordshire Partnership with a dedicated focus on mental health and wellbeing. So I've only met once, so it's work in progress, but wanting to put that lens on the delivery of the strategy and the plans that we're all looking at today. I suppose it was just to flag that at the last collaborative meeting, so that's the 2 counties, it was agreed that we would fund what we're calling a comms and engagement officer, but somebody to do some of the heavy lifting on what is actually out there. And obviously much of this fits into the Talk Communities review, and then start to basically be really clear on who does what. So previously we've had directories, so it might have captured everything that was out there, but feedback is that people don't know what services you can refer people into, what the thresholds are, and what's their focus. So it'll be more than just pulling the services into a directory. It'll be much more of a roadmap, which we can then all use to signpost to our communities, individuals, and across the system. So a lot of that will be done at that sort of PCN locality level, because I think that's where we could really get more traction on earlier preventative mental health and wellbeing. And then finally, I suppose, mental health, when we talk about it in this way, is really a very encompassing, overarching banner. A young person, first development of schizophrenia is not the same as an older adult developing dementia. We've got eating disorders, forensic, let alone the more generic resource. So I think what I liked about the plans, we've started to do bits which are absolutely for people with severe and enduring mental health problems. So their physical health checks being a key determinant of their longer term outcomes and a real health inequality at the moment. So I think we've probably just got to see that the plan will have to have that level of detail, but actually we also need to get more specific, I think, into some of the particular pockets that we're talking about in relation to mental health service access, because some services are very niche and we probably haven't got concerns about access, but we have got concerns about access sitting in our more generalised community pathways. So I just wanted to make those points, Chair. Thank you.
Thank you.
Yes. Hi, Lindsay. Sorry, I'll just quickly introduce myself. I'm Jo Lilly. I'm the communications lead for the Community Wellbeing department. With regards to the communications, if you want to link in through me, then we can get a comms plan sorted out, and I'll support you through that. Okay.
Yes, thank you. I'll be in touch.
Thank you, Chair. I was going to ask the question whether we believe the action plans were challenging enough.
stretching enough, ambitious enough, which I think you referenced, but I guess that's the challenge for us as a board in terms of delivering on these priorities. But I think linked to that, my main question is, when can we expect to see the outcomes dashboards populated and agreed? Because actually that's the means by which we will really determine what difference we've made. The actions are the actions, but actually the outcomes dashboard is what will tell us whether we've had a real impact. Thank you.
Oh, yes, please, Matt. Yeah, it's a really, really fair challenge, Hilary. So I think one of the things I was going to go on, I'll come back to your question in a minute, was obviously the colour coding within the action plan. So I think when we did review the health wellbeing strategy, you'll all remember about a year ago now, and one of the things we realised, building on what Hilary just said, was we weren't quite clear, did we achieve what the strategy set out to achieve? Was there an underpinning action plan behind that strategy? And what we found that actually there wasn't. So what we wanted to do this time around was to really have that kind of, for want of a better word, a golden thread, if you like, to identify the high level outcomes, the ambitions, and then link those through to kind of data and metrics and how we measure that. And that's really what the action plan is set out. It's obviously it colour codes the outcomes and the resulting actions that might deliver against those actions. I think it's a fair point that Hilary said in terms of actually, are those actions really going to make a dent on some of those outcomes? We just alluded to oral health, didn't we? And we know there are some big things that we probably need to consider as a board and wider partners, particularly on that subject. But I think it's a fair challenge, and we probably need to have a look at that to make sure these things are ambitious enough as partners. And also, this is not just a public health thing. This is a whole partnership thing. We all need to work collectively together on that. So back to the dashboard. I probably anticipate for the next board we could probably bring that back. I mean, we are obviously got Best Start in Life. I think it's the first priority we're going to bring in March. So whether that's the first dashboard we want to look at, and then the mental health one in June, or we could look at both the dashboards in March. That's probably something for us as a board to think about. Rob's fortunately with us here today, so he's also helping us pull that dashboard together. And again, we just need to be realistic in terms of what our targets are against each of those actions. And are we actually going to influence change on those outcomes? One of the things I'd like to do within those outcomes dashboard, it is a very draft dashboard. I'd just like to make that point in your papers today. I think it was just to iterate where we're going and what we want it to look like. It does need some more work. But I would like to see more inequalities metrics within there. So it's not just reduce childhood obesity, but actually reduce childhood obesity within the most deprived communities within our wards. I think we need to work through a little bit more on that, work with our partners as part of the action plan. And then obviously, I saw David's hand kind of there as well. We might need to link that through to the ICS strategy. I'm trying to hijack your point. You might not be making that, David. But so I hope that answers your question, Hilary.
No, it wasn't that point. But
it's
a good point. All the same. I mean, what I was looking at was the ambition. Obviously, I'm looking at page 79 at the moment, and the provisional outcomes dashboard for Best Start in Life. We know there's a very, very strong link between obesity and deprivation. Obesity is highest in the most deprived communities, lowest in the least deprived communities. And I was looking at some data recently where it's doubled in the most deprived communities but stayed flat in the least deprived communities. As an ICS, we are not a high deprived ICS area compared to others. Yet our figures suggest, when we look at that we probably are, if we apply that logic. So I'm just trying to understand, do we know why our childhood obesity levels are as high as they are, given our deprivation profile across both counties? And is it something that we should be specifically looking at, because it's such an important measure for future health and well-being as people grow older?
I know Kristen's here as well, but I don't know if she has the answer. I don't think we actually know the answer to that, David. What we do know, it does follow the national trend, but like you say, we don't have the same levels of deprivation. I know the numbers are small, so I don't know if that impacts on the kind of quality in terms of the statistical relevance of that data, but we don't know. It's similar to oral health, actually. I think oral health isn't correlated with deprivation in Herefordshire, is that right? I don't want to open up another can of worms here, but in some of the parts of the country it is. So I think the rurality of it, and IMD isn't always relevant to rural areas. I think that plays into it, but again, we'd probably have to do a bit of digging. It's a really good point, and something maybe we could look at. But Lindsay, do you have anything to add on that?
Thank you. I was just going to add that we're trying to do some mapping at the minute, so that we can see from our oral health data. So we every 2 years we do a survey of 5-year-olds. It's a random sample, but we've actually made it much bigger. so it's less random, if you like. But we want to map where the oral health needs are showing for our 5-year-olds with decayed, missing or filled teeth, where our schools reporting around the National Child Measurement Programme suggests we've got children who are overweight or very overweight. And then we're also looking at other data locally about some of the like Stride Active, who work with schools and have been doing some work with schools to see if we can do some other kind of more sophisticated mapping. It's quite tricky, but because it's a good point. We don't seem to have obvious pockets. We have some obvious pockets, but actually for things like our overweight children, they're across the county, and then it changes again in year 6. So it's not straightforward.
Yeah, and of course, I mean, I'm stating the obvious, but these things are inextricably linked, aren't they? Poor diet, high sugar, tooth decay, weight, etc. So we would expect to see a kind of a correlation, wouldn't we, in that area? But trying to get underneath it is pretty critical.
I think that was a question at the last board, which one of my colleagues has taken up around the link between obesity and oral health. So you intuitively think that's the case, wouldn't you? I don't know where they've got to that, but I think we need to bring that back to the board. That's a good point.
I agree with you that obesity is linked to areas of deprivation, but I would possibly query whether the link now is as great as it perhaps was. I sort of represent an area which would not be considered an area of deprivation, and yet there are a significant number of young children who are overweight, and the ability to purchase junk food is just as easy for some people who are have got money as it is for people who are living in deprivation. So I'm not so sure whether within Herefordshire, I think that's been shown in counties where it's more easy to identify areas of deprivation. But in Herefordshire, I think because it isn't quite so easy, it's probably less of an issue of deprivation, more of an issue of easy access to food that isn't appropriate. I'm not convinced that it is purely, mainly people that are on low income that buy junk food. I think there's a lot of people who are quite wealthy who are quite overweight.
I think, of course, it's not just about the food; it's about the wider the exercise and activity and everything else. But the national evidence, which, as you say, because of the rurality of Herefordshire and it is different. The national evidence is quite strong, but that's why it's important for us to understand our local picture, isn't it? Because otherwise, JSNA point in question from earlier, we can end up making bad decisions because we're not looking at local information, we're looking at national information. So accept what you're saying.
I mean, what we could do, we could bring a very short briefing back to this board, because childhood obesity is probably the best data we've got, because we weigh and measure probably up to 95% of children in reception in year 6. So we could bring a short briefing back, if that would be helpful, just to actually, so we could understand whether that does reflect what you're saying, David, and that might just help then address kind of, where we might want to target our efforts. And Lindsay, I'm sure that your group will be looking at that anyway. So if that's helpful, we could always bring that back to the board, maybe at the next Best Start in Life update, which would be March. Would that be helpful?
Thank you. I don't know if this sits with the 2 priorities or the JSNA or both, but is there something about detailed piece of work around understanding rurality and its impact? Because I think we've got quite a sparsely populated county, and a lot of it is outside of the towns and the city. And, the points David is making is we don't really understand it very well. And I don't know if there are tried and tested methods where we can do rural needs analysis, but that's almost the kind of thing I think we do need.
I wonder if we have it as a future agenda item and we do a bit of a deep dive on morality and we can look at that. Like I say, deprivation, we know there's been some analysis by the business intelligence team before in terms of the indices of multiple deprivation aren't well suited for rural areas because they're developed more on an urban spectrum. So maybe understanding that might help with some of these conversations. So yeah, we can take that away. Maybe not the next one, but the one after that, we could put that down if people think that's
Yeah, I
helpful.
mean, we've certainly talked about in the past the fact that if you live in a rural community where there's no public transport, in my area in particular, but there are others, taking a child to the dentist in a market town, if you don't have more than one car, is almost impossible. And so therefore, there is likely to be a significant issue regarding children getting not just their teeth checked, but also issues around ophthalmology and things like that, because there isn't that option. I've talked in the past and people have sort of poo-pooed the idea, but why don't we consider, I know financially that would be a expensive thing, but a sort of mobile dental vehicle like we do with a mammography unit, which goes around the rural areas, which actually checks, goes to the schools rather than expect the children to go to the dentist, and actually checks the children's teeth, because certainly in parts of my area where there is no public transport at all, I know the children, the parents will struggle to get their children even to Leominster because there's no buses, so they've got to have either a weekend appointment or there is no other choice. So it is a real issue about the fact that if you don't have public transport, how do you get your children to have their eyes tested or their teeth checked, even if there was a dentist available for you in Leominster or wherever, Golden Valley?
I mean, I would say I would agree with you that finding ways to get the services, but not just the money, it's the workforce. We've got money allocated to spend on dental services. What we can't find is dentists who are willing to take the NHS pound to provide the services. I think it's an idea that's worth pursuing, but it is a workforce challenge rather than a financial challenge for us. Actually, I think that's the key thing. The way the dental contracts are set, and the way in which the price is set, and things like that, it's got to be more attractive for dentists to do it, to come into the market in the whole. What we really need to appeal to is the high moral dentist who wants to go out and make a difference for children in communities. It's the kind of the moral heartstrings element rather than the business aspect of it, if you like. But I think it's a great idea to try and get services out to the communities, and that's what we try to do with our prevention outreach services that you will have seen and heard about, and we will continue to look at those.
Move to the recommendations that are printed, and we do have an extra recommendation, Henry?
I noticed that on the slides there was an added recommendation to agree to twice yearly updates to the board on progress against each implementation plan.
Right.
There was a recommendation to potentially bring an item on the outcomes dashboard to the next meeting in March.
Yep.
Matt also mentioned to bring back the item on oral health to the board at the next meeting.
I think that was around obesity, but we probably have oral health updates later in the year, if that's okay.
And the final recommendation that I captured was to bring an item on rural deprivation to the board, but that would likely be to the meeting in June. Yeah. Okay. Yeah, that was it.
You'll probably take that length of time, I would think, to get that information. The recommendations that we've missed? No? So all those in favour of those recommendations? Any against? Any abstentions? That's it. Thank you. Mm. 9, which is the community paradigm update, which will be presented between Hilary and Christine.
So if I kick off,
Yeah.
I'm not going to go through the report word for word, but just highlight some key points really. So throughout the ICS strategy, throughout the health and wellbeing strategy, we talk a lot about prevention. What we've been trying to do through this community paradigm approach is kind of think about how we can really invest in prevention that makes a real difference to people's lives, and pivot away, I guess, from that more established, quite traditional commissioning and procurement approach, which is not to say that that traditional approach doesn't have its benefits in the right place, but this is more about how do we build capacity at the grassroots, I suppose, more about community-based solutions. So we launched this work in March of this year, and we brought together leaders across a range of sectors to explore it and work through further. And the visual kind of strategy for the next 10 years is an appendix to the report, and very much aligns with the health and wellbeing strategy vision for that 10 years. I think when we were reflecting on what that community paradigm approach means, there's almost a set of principles which are at paragraph 9 of the report, which I think are really important. I won't read them through in detail, but this actually does require some quite brave and different leadership in order to deliver this approach. It's essentially about doing with people, not to people, and I know we talk about that, but this is actually how do we do that in reality. And reflecting that we probably need a different approach to commissioning and different forms of financial support that work in different ways. So in a sense, we've done quite a lot of work around the background, we've done a lot of work around the issues and the principles, and the reflections are actually moving from some of that conceptual stuff to implementing has been a bit problematic. I think the word community paradigm probably doesn't help, because what does that actually mean? And paragraph 11 says that we were talking about Herefordshire 2033, not saying that's the right wording either, but we're trying to essentially move away from wording that didn't make potentially much sense to everybody. I think the other part of it is that whilst there's a lot of enthusiasm, we actually need some dedicated support to kind of move this work forward. So we've got some joint funding together through organisations in Herefordshire to fund a post we're hoping to have in place for the start of the new year for a 12 months fixed term contract to move some of this work forward and actually be the legs to do some of the work. We've identified 6 work streams. Again, I won't go through them in detail, but happy to respond to any questions. And they look at different aspects of how we build that community paradigm approach, from community-led decision-making to a community chest approach. And I guess people's eyes immediately turn to the community chest and the finance, and it was alluded to in the report earlier on the health and wellbeing strategy. But that's again about how we test out a different way of funding and supporting communities to develop their own solutions to their own needs. I just want to finish, Chair, by just saying I think there are implications for us as statutory sector of this approach. I've already alluded to it, that driving that more proactive approach means that we do have to change the way in which we commission currently. At the moment, we do focus on large-scale commissioning, and I'm not saying that there isn't a place for that, but actually community paradigm suggests that we'd be moving to that much more of that early intervention and prevention focused around communities and what communities see are the local needs and the solutions to them. So as I say, it doesn't preclude it, but it makes us think in a different way. It makes us really challenges us in terms of what we want to do going forward. I think the other bit I'll just finish with is that no one's really cracked this across the country, and we're kind of learning this as we go along. Different places have done it in different ways. You've referred to Wigan earlier on, Chair, and the Wigan deal is an example of that, very much of that community working. That's the kind of thing we want to do, but build on it and across all sectors and really embrace it. So I think it's kind of a work in progress. I think the work streams and the resource that we've committed to will help us drive it further forward. And obviously be happy to come back to the board and update further as we go forward. But I thought it was important to at least give you a sense of where we are at the moment. I hope that's been helpful.
Yeah, a couple of things to add. I think Hillary's right about elsewhere not having cracked this, and in a way, it, you know, with all the challenges Herefordshire has, we felt quite strongly that we needed to start this journey as a cross-section of organisations and not one agency, because I don't think the kinds of solutions we're looking for can be achieved by one agency. And I think the examples elsewhere very often have started in one camp, so a local authority or a partnership between two agencies. So it is quite ambitious, but I think the gains are potentially greater by doing it right together. The second point is the flyer in the pack around the initial community chest. So Matt has agreed to fund an amount of 150,000 for the first attempt at a community chest approach, largely aimed at trying to encourage grassroots initiatives around the two health and wellbeing priorities, and we anticipate that going live with the Community Foundation in early January, around the 10th.
I think from my point of view, it's a challenge. It's a real challenge. I've only been in Herefordshire 9-10 years, but I think if any county can achieve it, we can. I've lived in other counties, and I think it's more difficult. It will be more difficult, but I do think there's real opportunity here, because there are because we are so rural in the main, there are lots of communities that are doing lots of things within their communities that would welcome this opportunity, actually. So, you know, I think it's exciting, but I think it is a huge challenge.
Yeah, I would agree completely. I think there's a growing willingness from the VCS sector to embrace this, but they sometimes, especially the smaller charities, struggle to see where they fit into the bigger picture. But it is the community chest element is really interesting in terms of it has obviously focused people's minds in terms of there's resources available. I think the initial feedback was this is wonderful, but it's a bit short term. Can we actually look longer term? And I think at roughly the same time, certainly on my inbox, the Safe Communities Fund sort of came out, and you're thinking, well, shouldn't that be in the community chest if we're all pushing in the same direction? So it was just observations really in terms of it's potentially very powerful, but there's still things to look at and consider.
I agree with you, Steve, and there's probably a bit of wherever you start, it's never going to be the right place. So I think I absolutely accept what you said about the funding, and part of what Christine and I are committed to is looking at how we, you know, as we go forward, is how do we bring these together so that we don't have this what looks like a fragmentation. But I think there's an inevitability of wherever you start. You know, we're not starting from a blank sheet, are we? And there will be things that we will need to, hopefully as this approach and as it embeds, actually it will become seamless and won't feel like that.
but I accept that at the moment we are a little bit where we are, but at least we recognise it, so I suppose that's positive.
Mike?
Yeah, I could see me being loaded onto the board. Hello, everyone. Apologies, I was a bit late getting here today and I can't be there in person. Clearly, I'm very supportive of the community paradigm and taking some of this forward. I think just one of the challenges, though, for us to consider came from a conversation I had at, just as an example, at the community partnership meeting, where I was approached by a mental health charity, one of the VCS, asking really about trying to make sure we get better contacts with general practice. And what was interesting to me was that, you know, we have a number of charities in the mental health arena, and I'm sure this will go across the VCS, almost competing for the same patients in the same way as health and care has often done over the previous years. So one of the things I'd like to just, it's a small challenge back. I'm not expecting Rome to be built in a day, but one of the things would be really helpful, and whether this is the opportunity connected with the paradigm and the community chest, would be kind of how well the kind of VCS could integrate and work together in a collective way to support health and social care services. It would just make things a lot easier for patients, a lot easier for formal services to work with the VCS. And I appreciate that has its challenges, but I think it's a reasonable challenge to at least consider, particularly when we're talking around supporting them financially. And it's just so I just thought it was worth raising at this meeting.
Thank you, Mike.
Yeah, I don't disagree, Mike, and a lot of the work of the community partnership is bringing people together to try and stimulate that collaboration. And there's pockets where it's working well, and there are still plenty that don't engage with that. One of the challenges, of course, is integration, as you know, is quite tricky. And you have big organisations to do the integration. I think one of the challenges for the VCS is they're trying to survive to the next month and the next month. A lot of it is voluntary, and there isn't a strong infrastructure behind it. And I think one of the enabling conditions and part of the 6 strands for this new role is to think about how we beef up that support that sits behind it to coordinate things better. But it's challenging at the moment when there isn't really significant funding going into the infrastructure for these things.
Familiar territory, Christine, from certainly from trying to pull general practice together in a similar way. I know it's different, we've got different organisations, but actually I do think there's ways of a formal infrastructure to work with the VCS and support them as well, and certainly would be happy to help with anything on that front if we can.
Thank you, Mike. Anybody else? No? Okay. Then we move to the recommendations as printed. And is there any other recommendations that anybody wishes to add? No? Okay. All those in favour of the recommendations as printed? Anybody against? Any abstentions? No. Okay. Right, we now move on to item 10, which is the Health Protection Assurance Forum Annual Report, which was going to be presented by Sophie Hay, who was the health improvement practitioner, but unfortunately she's unwell. So Rob Davies has kindly agreed to present the report. Thank you.
Thank you, Chair. Yeah, just to acknowledge Sophie's and others partners involved in health protection's contribution to this report. It very much was a collaborative effort. The purpose of this item is to update the Health and Wellbeing Board on the health protection system as a whole. both its performance, achievements and risks for 2023, as well as its areas of focus in 2024. There hasn't been a report of this kind for a number of years, mainly because the board itself was being redirected to COVID for a number of years. So it's a sort of re-establishment of the broader focus, not just infectious disease, that we've compiled across Wye Valley Trust colleagues, NHS England colleagues doing screening, some GP colleagues, very much a partnership effort to get the lay of the land of different health protection issues, compile it into one report to fulfil the sort of role of this board, to kind of fulfil that statutory role of seeking assurance that the right preparations are in place, the right systems are in place, and to protect the health of the local population. So the report is there for your viewing. Just to highlight a few things. I mean, I think broadly speaking, when we compare ourselves to England or region or similar local authorities, we do tend to be at an average or above the average in terms of immunisations, our population screenings of that nature. And in some areas, we are leading the country. For example, in the human papillomavirus programme in schools, we've far exceeded the national target, and we're amongst the top, I think it's the top 4, top 10 in the country. Similarly with seasonal flu vaccinations in the over 65, we've exceeded the national target by some margin, and particularly given the demographics of our local area, that's a lot of people who are now protected who otherwise wouldn't be. And on the flip side, while we still are performing high on a lot of child immunisations, for example, measles, mumps and rubella vaccination, we still want to do better. And that's one of our major childhood focuses next year. There's been a bit of a measles resurgence and clusters in London and elsewhere, spreading throughout the country. Our current rates are about 93% on the first dose, which is high for England. A lot of people are trending down, but we need to be 95 or above to get that herd immunity to minimise outbreaks. So we're shooting for that best practice target again. So we're working with our PCN colleagues and Worcestershire colleagues across an ICS footprint to develop more of a measles elimination focus next year. As just one example of where we are either good or average, but looking to be even better than that. On the flip side, where we are underperforming, but also in line with national trends, an example of that would be breast cancer. So since COVID, there's been a lot of backlogs in who was invited to screening, and that is the same in Herefordshire as it is nationally, and there's been a huge amount of work from NHS colleagues to get through that kind of backlog, but those do exist and they still show up in the data as not where we have been historically, and looking to catch those programmes back up. So the report outlines the different partners' involvement in different elements of health protection: screening, immunisation, COVID, sexual health, drugs and alcohol, TB and environmental hazards. So it's for the board to receive this report and query the Health Protection Assurance Board with any further updates or further queries as a result of this one. Thank you, Chair.
Some of this I have to admit I don't understand, so forgive me if a question I'm going to ask you is a stupid question, but there we go. Under the section on AMR infections, do I read from this that the overuse of, if you like, disinfectants and such like actually means that if you use it, everywhere, and you're always sanitizing your hands, you're more likely to contract or be not contract, but to be drug resistant to pathogens. Is that correct?
So I think there's probably a distinction to make between antimicrobial resistance, which is specific uses of sort of antibiotics or antimicrobial prescribed medications in the community and elsewhere, as opposed to necessarily sort of more cleaning practices. Those would be different. the reason there are, for example, elements of infections that don't respond to the most routine drugs is more to do with the former, like long-term prescribing over generations, or not completing prescriptions for antimicrobials. Yeah.
So that's what you refer to as misuse, or overuse.
It can be.
Yeah.
There's multiple reasons.
So it's not a case of when I was a kid, mum saying a little bit of dirt doesn't do you any harm.
I suspect that's quite peripheral, although it's good for the immune system to challenge it in all scenarios, yeah. The risk mainly relates to long-term use or non-completion of antivirals, antimicrobials.
Anybody else have any questions? No? Oh, yes? Get that.
I might be off beam as well. I don't know if this is two things that arrived for me following on from what Carol said about chemicals. I don't know if it would come under this remit, the fact that I've got a couple of friends that are cleaners and they've got horrible lung problems now because they've been inhaling horrible cleaning products. So that's something that is quite worrying, I think. And secondly, the black concrete in schools and other public buildings. Does that come under this or not?
So I think some of that comes under environmental health sort of regulations. So we do have assurance from that. I could follow up with the specifics on those issues to get more clarification. I realise some of the report is more packaged in a way that it's highlighted the main risks rather than all of them. So without the detail at hand, I wouldn't know the specific risks for that or what we're doing about it, but I could certainly follow that up. It would be within the boundary of the group to follow that up.
Question I was going to ask, I was looking for it, so that's why I let Diana go in there, is you talk about there's been a lower take-up of vaccination for shingles, and then you've also talked about pneumonia as well amongst older people. As somebody that falls into that category, into both those categories, I think, I've never in my group practice been offered a pneumonia or shingles vaccination. So that might account for why the figures are as they are. I had COVID vaccine and my flu vaccine, but nobody has mentioned to me or my husband, who is 81, about pneumonia or shingles. So there might be a need to perhaps get some practices, group practices, to push this more, because that might then make the figure a little bit better. Like,
yeah, well, my point is actually linked with that, Councillor Gandhi, because I was just conscious that I think it's a really helpful report, is just to understand how these are operationalised in terms of the conversations that take place that challenge interagency to actually manage this. I know that there's the kind of the place-based meeting and there's an ICS one, but I'm conscious it needs to get down to the kind of more frontline level, so that it's not just about general practice, because I do understand that there will be times when things like pneumovax and shingles need to be promoted. But I think this is an all-organisational approach that we need to be considering, making every contact count. And I'm not sure that we share the burden of those of some of these things effectively. So, for instance, we leave sexual health to sexual health services. We leave certain vaccination like flu to general practice or pharmacy. I'm just keen to make sure, how do we adopt an all-agency approach so that we make every contact count and make any of these programs more effective?
I think you're right, Mike.
Yeah, thanks, Mike. And I think that you beautifully outlined why this report has come to the board, because that is exactly the reason why. Because actually, this is everyone's business. I know we use that cliche quite a lot, and we talk about prevention. All of this stuff is preventative. So it's really important we focus on this. The other point for me is about how it links to health inequalities agenda, and we learned quite a lot during the pandemic, didn't we, in terms of how we engage those seldom heard communities. So why aren't people taking up vaccinations? Is it about a process
within the system, they're not being invited? Is it about fear, anxiety, culture issues, or a whole range of other issues? So I think that's something for us all as organisations, is how we try to address some of those barriers and increase uptake in a lot of these immunisations and screening programmes, which we know will have a significant impact on people's health outcomes. And that's ultimately what we want to achieve. So we proposed, we brought this report to the board, I think it was about 6 months ago. This is the first time we brought the report back. I thought it was really good, really comprehensive. And like you say, Mike, it's kind of, okay, the so what question, isn't it? And I think, you know, Rob's put in some key kind of future work programmes that the forum will take forward. And I guess it's having the support of that board and unblock any issues, I guess, in terms of, you know, where there's challenges that exist that we can help.
Yep. All those in favour? Any against? Any abstentions? That's the conclusion of the meeting. And I'd like to thank everybody for attending this afternoon. The date of the next meeting is the 11th of March 2024 at 2 o'clock, and I formally close this meeting. Can I check with Democratic Services team that the live stream has been switched off?